All right, to set the stage for this episode, I actually saw this position statement posted not only on a Facebook community that we're both part of, but my husband also shared it with me, just kind of like, "Oh, Mel, look what's been created," and I thought, "Oh, awesome! I can't wait to have Jess on to talk about this because." A lot of this information kind of gets buried. So you can read something like this and think, oh my gosh, someone's put a lot of time into this to help not only our profession, but just to help healthcare in general. What can I do to help, spread the word, but also just start some conversation and some brainstorming about how we can get this out, for the betterment of, like I said, the profession and healthcare. So, Jessica Adaszynski, thank you for taking time out of your day to help discuss this with me. Um, will you take some time to introduce yourself and maybe share some of the amazing things that you've been doing lately?
Thank you. Yeah, so my name's Jessica. I've been a registered physiotherapist since 2011. I've been practicing in pelvic health specifically since 2018. The first portion of my career, I really did more adult neurological rehabilitation. Um, Almost my entire career has been spent in the public health sector, although I do have a small component of my practice that's in private practice. It's a fee-for-service model, full circle physiotherapy coquitlam. Um, I'm also super proud member of Physiotherapy Association of British Columbia. I've been so since I was a student. And I just want to acknowledge, when I'm speaking today, I'm not speaking on behalf of the health authority that I work for. I'm not speaking on behalf of the Physiotherapy Association of British Columbia, just as, a physiotherapist that's practicing pelvic health, and certainly on behalf of my colleagues that helped contribute to this position statement as well, Sarah Hubbs and Adrian Sim. I think the other thing I just want to acknowledge is that, speaking to you today from the traditional and unceded ancestral territory of the Coquitlam First Nation, and just want to thank them for hosting me this morning to be able to do this talk as well.
Awesome. I actually also used to work in public practice. So for the first 7 or 8 years of my career, I worked in public practice where our job as physios was to, help people recover from whatever procedure they were having or, an injury they had had. And so I was so used to that model of, people from Canada have the benefit of our healthcare system that, enables them to have access to that, no matter who they are. And it was actually after having a child that I realized that nobody gets that care in that setting. And so if I wanted to work with those people that had, I always say, like the embarrassing issues, like the incontinence, the prolapse, the pain, but not, I never saw those people. I never got requisitions to see them in the hospital, and there was no jobs in Kelowna that I could apply for that worked with those patients. So I had no choice but to work in the private setting. And obviously, after you work, I've been working in the area now since my daughter was born, so 12 years. And you see so many benefits to what you can provide as a physiotherapist. And I want to talk a little bit more about that, but I definitely I don't want to say cower, but there's definitely times where I feel sheepish that I'm not able to provide that service to everybody because there's a lot of people that cannot afford to come to the appointments, or I know they're just not having access if they haven't heard from their doctor or their friend. They don't even know that it's an option. And so I think that's one of the biggest reasons I started the podcast is just what can I do that offers free information, provides some education, but there's so many other things that we can do, and I think that's what part of what you were all getting at with this position statement. So what if we start, Jess, a little bit with just kind of before we get into the details of the position statement, can you talk a little bit about like just overarching what are the benefits of pelvic health physio?
Yeah, for sure. I mean, within the position statement specifically, we've actually pulled out some specific, I guess, patient groups that can benefit the most from pelvic health physiotherapy. But overarching, I think I look at us as primary healthcare providers that really need to be involved across the healthcare continuum, but also across somebody's lifespan. And so there is wording within this position statement about perhaps the role of pelvic health physiotherapy being involved with people younger in their life in order to give them education about their body, in order to teach perhaps strategies or exercises on what we'd consider maybe an intact pelvic floor, ahead of perhaps childbirth or things like that. Um, and also, to, I guess, educate people about the processes that are going to happen as they age that are going to impact their pelvic floor health. So when I think about this document, we're looking at it from someone's entire lifespan, and then also all the different places that we could fall under across the healthcare continuum, whether that's in private practice as a fee-for-service model or really integrated into the healthcare system, especially in places where we know there would be the greatest need. And so peripartum healthcare is a great example of that, and that's specifically mentioned within the document.
Yeah, because at the end of the day, we know there's a lot of high quality evidence that supports pelvic health physio for, treatment of incontinence, prolapse, pain. Like we have the evidence, right? And especially and even saying that it should be the first line before things like surgery in a lot of times. It's hard though when a surgery is almost easier access for a lot of people, right? We know again
Mhm.
there's lots of benefits for treating a lot of these symptoms, but it's almost not common knowledge and it's not utilized in the healthcare system. Can you can you talk then a little bit about, just for listeners, like what exactly is a position statement? Because I think essentially, what's come about is that there's an obvious need, clinically and according to the research and different guidelines out there, but we've already kind of alluded to the fact that it's not being utilized to its full extent. So, what exactly is a position statement, and why did this come about?
Yeah, thanks. So a position statement very generally is, a list of recommendations or essentially beliefs of an organization. It's conveying that viewpoint of the organization and perhaps provide some context around why an organization is going to pursue certain strategies or provides basically the context around their decision making as well. So it's a document that they can provide to their members, that they can provide to other organizations that they're working with, that just succinctly talks about what their viewpoint is and what they believe. Once a document like this exists, and actually this position statement references essentially other position statements, which is really funny, like the work that's come out of Ontario. Once that exists, you have something as an individual or as somebody that's working within a health authority or somebody that's working with provincial government to be able to go look at this. This is kind of like giving us almost like the strategy of how we enact this.
Hmm. And so, a few of you get together and you create this position statement. And can you talk a little bit about some of the other things in it? So we've talked a little bit about kind of basically like you acknowledge in the position statement the benefits of, pelvic health physiotherapy and some of the other things that are being done. Like, can you share a little bit? You mentioned in Ontario. Can you just talk a little bit about when you say that can you share with everybody like what's being done in Ontario or what has happened in Ontario?
Yeah, for sure. I actually like just for my own knowledge have to go back so I actually correctly identify
Mhm.
what the document was. When I talk about what is happening over in Ontario, so Health Quality Ontario in 2024 put out a statement around pelvic floor muscle training for stress urinary incontinence, fecal incontinence, and pelvic organ prolapse. And so that was really like a summary of the available evidence. And when we're talking about evidence, I mean like very high quality. We're not talking about one-off or randomized control trials. We're talking about systematic reviews or other means where there's been a lot of data collected that they can analyze, that basically is strong enough to justify why the health authority in Ontario is going to fund this as treatment. So they were referenced in this document. This is not a health authority, but for example, Canadian Physiotherapy Association also put together some content around, and this was to the federal government in terms of what they should consider funding based on the available evidence. And yeah, so documents like that in my mind are very similar to what we put together here and actually help to strengthen this document as well.
So anything come to fruition in those regards with the federal government and in Ontario? Like any changes?
Yeah, so in Ontario specifically, and I apologize, I'm a little bit ignorant around it, but my understanding was based on those recommendations, they did actually remove funding from certain conditions because there wasn't the evidence, I guess, to support pelvic health physiotherapy playing a role there, and reallocated funds, in order to prevent fecal incontinence, urinary incontinence, or how that's delivered under OHIP.
Okay. And so tell me, so let's talk a little bit about some of the acknowledgments in the position statement around what are some gaps. Like, we've mentioned that, the benefits are that we know that it's an evidence-based um, first line treatment for people experiencing all those symptoms, but what are the gaps? Like what are we missing so far?
Yeah. So I think once you have that summary around like what is recommended from the scientific literature in terms of what we currently have evidence for, there's also like a little caveat in our recommendations saying the stuff that we don't yet have evidence for, but that anecdotally we can say, yeah, when I do these strategies, it does seem to be helpful. I think that, there is probably a lot of stuff that we actually can be helpful with. We just don't have that wealth of literature there because for some reason, this is not being studied. And so that's actually another recommendation is like we need to actually increase the amount of research that's going on around pelvic health physiotherapy. But just as an aside, once you have that down, what the evidence is currently there for, what we then did, and this is, again, somewhat our opinions as the authors of this document, but also based on, we've participated in, for example, like landscape surveys of what is currently happening in British Columbia. So we have a good awareness of where pelvic health physiotherapists are currently positioned. And so, it's a matter of there are gaps, quite honestly, in like the service delivery or like where they're actually positioned within British Columbia. So, the vast majority of where people practice in British Columbia is in private practice in a fee-for-service model. Um, and so inherently in that, there's going to be some equity issues, right? The people that are coming to see you either have, insurance that's often tied to employment, in order to pay for those visits, or they're able to pay for that out of pocket. And so that right there creates an inequity. But then, yeah, what does exist within public health? And there's very few places that there are a role, a unionized role for a pelvic or a physiotherapist practicing pelvic health. But where they do exist, they tend to be more specialty clinics. So they are providing what's considered like tertiary level care. So there's some sort of specialty condition that they are addressing, and chronic pelvic pain would be a great example of that. There's a new clinic at BC Women specifically around birth injury. And so when you look at that, those are not where somebody can walk in off of the street and see them as a primary care provider. There are going to be a series of things that people have to do, usually through either their GP or a specialist referral to actually access that within that clinic. So in that way, they're not acting in primary care roles. There's actually a lot of barriers to somebody accessing that care within public health.
I have a lot of patients that have questions around that kind of confusion around, okay, wait a minute, like when I had a knee surgery, I had my surgery. I saw a physiotherapist in the hospital for a few days before I left, and then they set me up with some therapy to go back to. And yeah, some of them go on to have additional therapy if they want that they pay for fee for service. But I've had a few people say it's kind of confusing that like after my surgery for my hysterectomy or my prostate surgery or my birth that nobody saw me. It was recommended by my surgeon or my gynecologist, but it was kind of confusing that I had to go to a clinic and pay for it. Like there's a lot of
Mhm.
confusion around that, and it is hard to explain. Yeah, you've drawn a very nice parallel. It's hard to explain why you have to pay for all of this versus have some of that built into your recovery program because it's happening more and more that people go to their family doctor for a symptom like incontinence or prolapse. Still, I would say, well, more often I'm seeing the family doctors refer to physio, but quite often they also refer to a specialist like a urologist or a gynecologist. And quite often these people wait upwards of a year to get in to see that specialist, only for the specialist to send to the physio. And so again, I find a lot of people feel quite upset about that. I could have had help earlier. And a lot of times they'll express that I can't afford the physiotherapy and the surgery they'll describe as it's free for me, right? And there's a lot of confusion around it.
Yeah, I think there's a few things that jump out at me and from what you just said there. So first of all, I think that analogy of what's the difference between, say, like a pelvic health surgery versus like a total joint replacement? And, in other jurisdictions in British Columbia, total joint replacements are often entitled to like 6 to 8 visits back at the hospital in some sort of outpatient setting. So perhaps in Kelowna, it's more of like a voucher system, or yeah, they're accessing private care. But some places they are entitled to, ongoing rehabilitation for that surgery. So I think that's a great analogy because, yeah, why would that be different, right? Um, and then also just acknowledging a lot of our pelvic health surgeries too are not elective, right? So if it's in relation to cancer or something like that, that's not a choice that someone has made. And yet there is no public service in order to help them rehabilitate after a surgery like that. Um, again, in some places, there have been projects where there might have been some funding that was allocated to pelvic health physiotherapy, but not as integration into that clinic. Again, the most common way that I see that play out is some sort of like voucher system where people can access care. But again, that isn't province-wide. That tends to be in this one jurisdiction. Oftentimes it's funded through like the Health Authorities Foundation or through other fundraising efforts, like through the BC Cancer Agency. So it's not actually part of like a capital budget for that clinic. So yeah, then a position is not created when that happens. Um, just thinking back to the other things that you said there. Sorry, Melissa, you had so many good points in that. Um,
Possibly that they have to wait so long to see the specialist.
Yeah, actually, thank you for jogging my memory there. So, also wanted to say, this is a real thing too. As a provider, if you are seeing somebody that you know has limited means, that's shared that with you, you are often hesitant to recommend things that you know are going to be out of reach for them, right? That's not really helpful information. Hey, guess what? The best line of treatment for this is this, and it's not something that you're able to access. So number one, I think that makes providers uncomfortable, and that's problematic because for a bunch of reasons, but it's not furthering that discussion of how we access that care for people. But it's also kind of like a very paternalistic view of how we communicate with our patients. We should be sharing what is evidence-based first line care and letting people make those decisions as well. Or again, then working on the advocacy piece where it doesn't exist. Yeah, so again, I hear that frustration where people are being sent to specialists, but then again, that is something that can be reimbursed by MSP. Those surgeries are reimbursed by MSP, and so it is an avenue that providers can recommend because there is something to do, and it isn't coming out of that patient's pocket.
I think I've started to notice, and I can't say that this is happening all the time, but I'm hearing some different messaging come from like out of the patient's mouth that has come from their specialist, if you will. For example, I think there was less referrals because of that discomfort around like, oh, I have to recommend you to something that costs money. Um, I'm hearing more messaging around you might need a surgery, but I really want you to see a physio before and explaining that I think your outcomes will be better. Like I don't want you to have a revision or I want you to live your best life after this surgery. So I think like I'm hearing more patients coming in reiterating that they heard this is what my surgeon told me is that yes, I might need a surgery, but they want me to maximize my recovery or hope that I don't need a surgery. So I feel like that messaging is changing a little bit, but I can imagine that it's hard for those specialists, if you will, to have to kind of refer out of the system for what they consider best practice.
Yeah, I think the other thing too is you have to acknowledge, although I'm sure there are private practice, physiotherapists practicing pelvic health that have strong connections with gynecology, with obstetricians, with urogyne, nurse continence advisors, whoever that might be that are housed within that public system. Even though there might be great rapport and there might be a relationship where there's communication back and forth about shared patients, I think that's harder to facilitate, right? Because it's if you're not within that system, it is much harder to build those relationships. If there was a physiotherapist associated with that particular urogynecologist office, that's a whole different ballgame. That's really streamlining that person's care, right? And I think there can be communication back and forth between those providers much more easily than there is when one is within the public system and one is excluded from that system.
Absolutely. So on that note, you've kind of alluded to something that would be ideal, a solution that would be ideal. What other recommendations did the position statement come up with so we've acknowledged, some of the downsides to how we're operating now. What are some recommendations?
Yeah, so there's some like very general titles, and I'll maybe speak to a few points under each of them. So the first recommendation was really speaking to leveraging pelvic health physiotherapy skill set in various capacities. So that looks like a bunch of different things. So we were very conscious when we wrote this position statement of the current landscape and also of not, I guess, invalidating that people are practicing privately. That needs to exist. There needs to be choice throughout the healthcare continuum. There always should be some option to access people privately. But also just acknowledging if we also think the future is integration into this public system, that there are multiple ways that that could happen, and that we also kind of need a transition plan for the in-between. If all of the expertise exists over here and we need some of that to migrate over to the public system, that we just need to be conscious in what we're recommending around that. And so, we talk about in the position statement adding physiotherapy, for example, to primary obstetric care teams. So that could look like FTE that is managed by a health authority. So FTE meaning full-time equivalency. So a unionized employed position within the health authority where perhaps some of that time is spent with that obstetric care team. It could look like the medical services plan of British Columbia changing how they are reimbursing us. So, as it stands, people can use MSP if they have like extended coverage through there to access physiotherapy care in British Columbia. But the premiums that are being reimbursed are incredibly low. And so, there are providers that won't accept that as a form of payment because they literally can't because it's so low, or there's enormous copay fees related to it. So it's another barrier to patients. But if we could, look at the fee structure around MSP and what they will reimburse for. So for example, visits around around the peripartum time in order to prevent stress urinary incontinence, in order to reduce the risk of an obstetric injury, you know, things like that could be reimbursed as MSP, fee for service by that provider. So they're not necessarily wholly integrated within that health authority, but there is a way that people are accessing that care essentially free to them, but reimbursed by MSP. Or we could look again at things like voucher systems where a certain number of visits are covered by a health authority, but the person has a choice in terms of who they seek out privately in a clinic for that care. Um, we also talk about upskilling physiotherapists that are already practicing in public health. And so the majority of them are, again, unionized employees with some sort of full-time equivalency. Maybe in some of these areas, particularly rural and remote or indigenous communities, we need to give opportunities to those people that are already employees in order to upskill so that they're able to provide these services in the communities that they live and work in. And then also thinking about whenever we're developing new programming that's going to impact patients' pelvic health, that we really need to have a voice of a pelvic or a physiotherapist practicing pelvic health at the table. So, if we're looking at developing, say, another clinic related to birth injury, we absolutely need the voice of pelvic health physiotherapy to be there when we're looking at developing those types of programs. The second large chunk of the position statement really, again, talks about funding for access. And so there are, I won't go into them in a huge amount of detail, but there are specific conditions that we pulled out of there. Stress urinary incontinence, specifically around peripartum care, as I've mentioned, and then the different ways that that could potentially be reimbursed. We've also talked about pelvic health physiotherapy awareness, and then education as well. So just thinking back to what you've said about providers as well, I agree with you that I think this is getting better, but it is still not universal that people are even aware what pelvic health physiotherapy is. This is also really common that we're talked about almost like a modality or as one modality when they really mean pelvic floor muscle training. So I think awareness also needs to focus on the fact that we're primary healthcare providers, that we are doing, a history, we're taking a subjective and objective assessment of that individual. We're coming up with our own physiotherapy diagnosis, problem list, and individualized treatment plan. And then the modalities look like a bunch of different things, right? So it could be pelvic floor muscle training, could be electrical modalities, could be fitting of a vaginal pessary. So perhaps we're somewhat there with the awareness, but we need to get the breadth of what we're capable of. More like it has to roll off providers' tongues as to why am I involving a pelvic health physiotherapist? These are all of the reasons why. And so then another aspect of what we're recommending is, around pelvic health physiotherapy training and research. We really think that, again, there needs to be more research happening at the universities in British Columbia around pelvic health physiotherapy, but also within the health authorities. And, that's another consideration when we're talking about where pelvic health physiotherapy is positioned, is that majority of research is often attached to a facility of some sort, right? So if it's clinician researchers, they're often associated with some sort of research hospital or place where they're acting as part of a care team, and there's multiple people, contributing to that research. It's much more rare to have somebody in private practice work with researchers at an institution in order to do research. And so, that's something that I think we need to consider as well, is that if we are able to move some of us that want to be there into public health, that's really going to facilitate knowledge translation and future research as well.
What we know that healthcare doesn't change quickly. Like that's everybody knows that. And we know it takes not only a long time for just research to make it to the general public or to make it to practice, Um, and obviously something like a position statement is going to fall in there too, is you take the evidence, you take kind of the landscape and mash it all together and try to come up with like these are some recommendations. Um, I mean, where do we see this going now? Like, what are, I guess what I want, one of the reasons I wanted to record this episode is like, what are we supposed to do with this? So, people listening, whether it be patients, other providers, physios, um, I think sometimes as physios, we don't feel like we have a very loud voice. I definitely find that in some projects I've been involved in our community, we really have to attach ourselves to someone that's a doctor. And so I guess I just wanted to brainstorm a little bit, like, what are we supposed to do with this? Like, we can talk about it, but you don't want it to fall on deaf ears or just to sit as this document. Like, what are we supposed to do?
That's a great
Great
question.
question,
So,
right?
and also the subject of a whole other podcast. No, I'm
Yes.
kidding. Uh, so I think within this document, when you get to the very end, the Physiotherapy Association of British Columbia, when they have endorsed this statement, is basically inviting partnership, allyship from other groups that might also be working around this space. There are other advocacy groups or organizations that exist that are maybe not physio specific, but are inclusive of physiotherapy. So it also invites partnership from the Canadian Physiotherapy Association. I'm just thinking like it's a call out to places like Doctors of BC where we can all come together as a united voice. And there are things that these types of organizations are going to be better at. So, there could be, there's a lot of rules around this, but there could be some way that they all partner together and are communicating this with the provincial government in some way. So there's that aspect of what an organization can do. And, PABC would really be better to talk about legally what they can do with a document like this. I think as individuals, though, what this document is useful for, when this was published, I sent this out to every obstetrician gynecologist I worked with and just thanked them for their shared care and just number one, made them aware that this is an issue because oftentimes
Mhm.
we're just looking within our own little slice and they have a public practice, pelvic health physio that they work with. So just making them aware, like there's huge gaps that exist elsewhere. I really think um, whenever we are in our own little practices, we absolutely are making connections with individuals that we can use to amplify this message, or we can leverage these relationships in order to get this message across. So, in thinking about what everyone can do out there, I would say, if you are in a position where members of your municipal government, for example, there are times when they host open houses or opportunities where you can go and talk to them about issues that you care about. Showing up with a document like this and just bringing that to their awareness would be one way that you can share that, right? If you are a part of groups, again, that are maybe not physio specific, but are around this area of pelvic health, bringing it up at your meetings, for example. There's so many different, I think, individual relationships that we can't see, but that are there that we can use to amplify each other's voices. And you mentioned like partnership with physicians. I have to agree with you that I don't know that the physiotherapy voice is as loud as some other groups, but certainly anyone that I've ever talked about these issues with, whether they're a specialist physician or nurse practitioners or nurse continence advisors, all agree on the importance of what we do and that we're a crucial part of this service delivery. And so, again, making friends with those people in your local area or thanking them for that relationship, showing them this document, I think are all great ways of spreading this message.
It's interesting. I just was asked to speak to a group of dietitians from the primary care network here in Kelowna that work with the different physician groups to be able to offer care to people that have dietary issues. And so I think, huh, interesting. Like just there's a group of them and that started somewhere too, right? I know that hasn't been around forever and they started somewhere too. So I think just sometimes it's just, picking the brains of people, just like where did this start or who should I talk to, right? It's definitely given me some ideas of who could I talk to because I've often thought before, what would it look like for me to do a bit of a hybrid? How do I work in the public system a bit? Because I would like to branch out, but so far there's just no option. There's no option right in front of me, I should say.
Yeah. Yeah, and I can speak to that too. My own journey in practicing pelvic health in the public setting, um, it it did and it didn't get presented to me. I did have to, over the years, talk to my clinical practice lead, my managers, obstetrician, gynecologists that I would meet at the hospital about pelvic health physiotherapy, what I'm doing, where I think we can be positioned, and kind of being annoying about it, right? So that hopefully, if there's an option in the future where something could be created, that they think back, oh, right, I know somebody that can really speak to this, or I know somebody that might be interested. I think you can also do that being outside of the health authority as well. There's definitely, no one would ever say no to having connection with physiotherapists that are maybe practicing outside the health authority, whether you're going to, um, you know, a provider that's not a physiotherapist, like, maternity providers within a certain organization, or even, again, clinical practice leads under physiotherapy. I think just having a conversation with them, hey, I'm in your community. This is what I'm interested in. If there was ever an opportunity to speak about this, to help guide some work around this, I'm available. I think those types of conversations, people remember them and they're going to be able to tap you on the shoulder if there's an opportunity.
Well, and I think you already alluded to this, but how many of us just get a bit stuck in our day? Like I can speak to like there's a lot of days where I go into the clinic, I see my people, and then I am shifted to mom. And so sometimes unless someone brings something up to me, oh my gosh, what a great idea. I just almost couldn't think about that. And I think anyone that works in healthcare would say they feel a lot of the same. Sometimes it's hard to just step outside of your day-to-day role and put on your thinking cap or think bigger picture. And so it doesn't mean it's not an option, but I think sometimes we have to set up those walks or those coffee dates. And can I just pick your brain a little bit? Because I think sometimes that's where things start, right?
Absolutely. Yeah. And like we can rely on our friends to speak on our behalf, right? I think having connections with people that are outside of physiotherapy, but that practice in this world of pelvic health are so important for that reason, right? And also our understanding, we can amplify their voices as well. It's the shared respect of what each other does and what we bring to the table, and really, yeah, building genuine relationships with the people that are around you practicing in this space.
hmm So, Jess, anything that I haven't asked you about that you feel we should make sure we include in this conversation?
I don't think so. I really think, um, we've covered mostly what was in the position statement, and we were very intentional about what we included in terms of really bringing it together of actionable things, that somebody can pick up and go with, whether that's, again, like at an organizational level within the provincial government, within a health authority, or individuals as well. So, I would encourage people to look to the recommendations, and see what's available to them.
Yeah, I think you guys have done an amazing job and I appreciate it. I mean, I can I can look at that and I know that it's a lot of time outside of your work time that you're dedicating to this. Most of these things nobody gets paid for. They're just people that want to make the healthcare, work better than it the day before. And so yeah, I appreciate you and everybody else that's put your time into this. Yeah, it's
Yeah,
not
I think
always
the
going
other
unnoticed.
Thank you. I think the other thing too is just to say to anybody that reads this position statement, it is a living document, and PABC has encouraged people to give them questions or concerns about it or feedback. And I also envision that as the landscape perhaps changes or new evidence is available, that we're going to have to continually update this position statement because it's not enshrined. It needs to change over time as these things develop. And so would really encourage anyone that has feedback or an addition or a criticism to connect with the Physiotherapy Association of BC as well, because they're encouraging that relationship as well.
Well, I hope we can reconnect in, not the too distant future with some revelations or some massive changes that we can say, remember when we had that other conversation? So I appreciate your time today and again, everything that you're doing. So thanks, Jess.
Thank you.